So there's lots to discuss with patients to diagnose them, to give them a treatment plan that makes sense to them, that they want to go through with, and that fits their lifestyle and whatnot. So we can really tailor make their regenerative medicine treatment to fit their situation. And even some of the treatment options we have, the more we process the blood and whatnot, it gets a little more expensive because I have to use more equipment, more staff time in order to make these different generation PRPs. So we add a little more cost onto it. Some patients, that's a burden to them. So that's where dextrose becomes really important in my practice. If a patient can't afford these more expensive regenerative medicine treatments, we'll offer them to dextrose. Hey, look, let's try this and see if this is strong enough. And if it's not, you can save your pennies and come back and do a more expensive treatment. In all my years of using these placental tissue products, they're no worse than a PRP injection. And they're usually much quicker to get through. It's usually just a day or two before you're through it, and patients are already noticing improved symptoms. So it can have a remarkably quick turnaround from injection to symptom improvement compared to our own tissue. So a lot of doctors like it because of that. We can just pull it out of a vial, inject it in our patients. The patients are happy, they heal up quickly, but when you compare each product side by side to what we can inject in our own patients, there's subtle differences and advantages of both. So one treatment might be, the placental tissue product may be the right tissue to use in one patient, but it's not in another.
Well, where do you think that this field is heading in the next 5-10 years? So there are some most exciting developments
There's I am in the process of transitioning my practice I've been working at for more than 15 years here, and I'm going to be moving to Florida in the fall, and Florida just announced it's going to legalize stem cells. So
wow, that's impressive.
now from my reading of the law goes into effect in July. From my reading of the law, we're still not going to be able to culture expand or incubate the cells and grow them and then use them in our patients, but we can use placental tissue products, and we can use the patient's own bone marrow, fat, blood to treat their orthopedic injuries. And some of the other things that we're doing in Mexico, we're doing IV treatments for an immune system boost to help their orthopedic condition heal better. I think from what I'm reading that we're going to be able to do some of that in Florida.
Cures, Remedies, and Beyond podcast with Dr. Irina, a Stanford-trained medical doctor, inventor, and a published author with over 30 years of clinical experience, is bringing together the science of medicine and the art of healing for ultimate vitality and health. It engages in discussions with healthcare providers, wellness experts, innovators, philosophers, spiritual and industry leaders, as well as health and wisdom seekers to provide you, the listeners, with practical tips and knowledge to help optimize your health and well-being. The Cures, Remedies, and Beyond podcast with Dr. Irina.
Today, our topic is non-surgical regenerative orthopedics and stem cell treatments. Chronic joint pain and musculoskeletal injuries affected millions of people each year. In fact, nearly 1 in 4 adults in the United States, or about 58 million people, suffer from arthritis alone, while orthopedic injuries account for over 25% of all primary care visits. In addition, statistics show that over 80% of adults in the US experience back pain, at least at some point in their lives. Altogether, this costs over $850 billion per year, just in the United States alone. Traditionally, treatments for these conditions have relied on pain medications, steroid injections, or surgery. But now, an increasing number of patients are turning to regenerative non-surgical orthopedics, a cutting-edge medical field that uses the body's own cells and natural healing mechanisms to repair damaged tissue and reduce pain and inflammation. Best of all, these treatments are minimally invasive, carry fewer risks and are designed to help patients to stay active without surgery. You might have heard that many prominent athletes have used these treatments to speed up their own healing, including Tiger Woods, Kobe Bryant, Steve Curry, Rafael Nadal, and many others in our US Olympic teams. To discuss these unique and increasingly popular treatments, we've invited a nationally recognized expert in the field of sports medicine and regenerative or orthobiologic procedures, a physician who treats both elite athletes and weekend warriors alike, a founder of the Center for Sports Medicine and Wellness, Dr. Brian Shiple. Thank you for joining us, Brian.
It's so good to see you, Dr. Arena. And we just were able to catch up at our national meeting not too long ago. It was good to see you.
Yeah, same here. Thank you for joining. You're not only one of the early pioneers of interventional regenerative movement, as I call it, but also an amazing teacher. You served as a president to the American Association of Orthopedic Medicine, where we just, catch up, as you said, a month ago. And that's where you tirelessly and very passionately actually teach younger doctors integrative orthopedic medicine approach, where the body is looked as the whole system. You teach cutting-edge image-guided regenerative injection treatments and diagnostic musculoskeletal ultrasound, and as I found out, spend 2 months per year teaching. That's quite remarkable. And also,
Yeah.
I actually didn't realize that you have appeared on ESPN and have been profiled in the American Milestones TV series. That is something impressive, Brian.
A few years ago. It's been a wild ride. We've been in practice for over 30 years, and my wife says I still jump out of bed to go help my patients every morning. So it's still what gives me a kick to help people and help them get better. And I'm sure you're the same way.
Yeah, well, and for those who may be new to this area, what exactly is regenerative medicine, and how did you become a specialist in this field, Brian?
So my formal training was in a non-operative sports medicine at Penn State, and my first job out of my fellowship training, I took a job at an academic center, and they asked me to develop a sports medicine training program, which we were the second in the Philadelphia area when we finally got our program open in '94. And I ran the practice, and I trained my fellows in the art and science of non-operative sports medicine. We worked a lot with orthopedic surgeons, and we came to know them and know what they were offering our patients, and saw that if we could not get them better with, like you said, a steroid shot, physical therapy, and anti-inflammatory medication, we didn't have a lot more to offer them. We sent them to surgery, and oftentimes the patients came back and said, "Hey, thanks for sending me for that surgery, but I'm still in pain, or I traded one pain for another. What else you got? You got to figure this out, doc. You got to help me." And we scratched our head a lot and went to our scientific meetings and read our literature and whatnot. And there really wasn't anything at the time. But eventually, a handful of years into my practice, I became injured in a motor vehicle accident on the way to the ER to do an ER shift. And I didn't realize it at the time, but it was a high-speed accident. My car got spun around a few times, and I was able to continue after the accident was cleaned up. I was able to go to the ER and do my shift. And the next day I started developing pain in my neck, in my back, in my shoulder, in my arm. And within about 2 or 3 months, I was struggling and looking for care and help and going to my colleagues, and they didn't have anything to offer me. And I had heard a lecture on prolotherapy, actually, back in the late 90s. And I said, I wonder if that could apply to me. And I ended up doing some research and found one of my colleagues practiced prolotherapy. And I went to him and had 2 treatments with him, and it saved my career. So now I'm very passionate about, hey, what is this treatment that I was never trained in, never heard of it? I started looking for articles on it and going to conferences to learn how to do it for my patients. And that's how it got started. And I often say that prolotherapy is the gateway, like maybe marijuana is the gateway to stronger drugs. Well, prolotherapy is the gateway to stronger treatments we call regenerative medicine with our own body fluids and tissues and whatnot. So that I did prolotherapy in my academic practice. I taught it. I practiced it on my patients. I was able to, with the help of administrators at a hospital with 7,000 employees, I was able to get it covered as a covered service for our hospital employees. We were self-insured. So I treated lots of doctors and nurses and orderlies and the general staff of the hospital. They were all coming to me for this prolotherapy care, and it was well accepted in my community, and it started going out regionally and nationally and whatnot. And then PRP came on the scene. PRP is platelet-rich plasma for the audience if they've never heard of that. And platelet-rich plasma is taking your blood out of your body, putting it into a test tube. We spin it in a centrifuge, and it separates the red blood from our plasma. And in the blood is white blood cells and red blood cells. And in the plasma is where most of your platelets are. We take that plasma section and we spin it again, and it concentrates the platelets down at the bottom of the test tube. We pull that out, and that's platelet-rich plasma, and we inject it into orthopedic injuries, arthritic joints, et cetera, et cetera. And then we learned how to do other regenerative medicine techniques like using our own fat. Fat has a lot of good cells in it for healing. Our own bone marrow has bone marrow stem cells. And that was kind of the launch of the regenerative medicine movement, as we call it, back in the late 2008, 2010, in that area. It really kind of splashed onto the scene. And our meetings became much heavier in not just prolotherapy, but in all these regenerative medicine techniques, how to diagnose, how to deploy these products into different joints and tissues. And then we got into spine, and treating patients' spine. I was always doing prolotherapy in the spine, treating patients with chronic back pain, treating ligaments and things like that. But then I got formally trained to treat the spine like an interventional spine doctor or a pain doctor that you would go to that gives you a steroid shot into a facet joint or on a nerve, an epidural, or treat a disc or something like that. So we started applying these techniques into the spine, and lo and behold, it worked there too. And now the literature has caught up and shows that treating the spine can be effective, and that's become really one of my passions, is treating the spine injured patient or patients as they age. They develop degenerating spines that are painful, and we have things to offer them now to help them heal without
Right,
surgery.
right. And just for some people who might not know what prolotherapy is, of course, using the dextrose solution. So can you just, quickly mention
Sure.
what that is?
Yeah. So I, when I learned about prolotherapy, I was actually at a meeting, and I was waiting and looking for a doctor to talk on prolotherapy. And this meeting had one lecture on it. And I made sure I got right up in the front of the group to listen intently on the message. And the doctor that showed up was not the original doctor that was supposed to be there. He was an old-time prolotherapist and a good teacher, but he was very anti-orthopedics. And when he got up to the podium in the front of 350 sports medicine doctors, most of us were working with orthopedic surgeons, and they were our colleagues. And he was not very nice to the orthopedic surgeons in his presentation about prolotherapy. So subsequently, most of the people in the audience left, but a handful of us stayed. I was one of them. And I went up to him after the talk and I said, "That was great. Where do I learn to do this? Because I've been waiting to hear about prolotherapy from someone experienced like you for a long time, and I want to learn how to do this." And he invited me to one of his meetings, and that was the beginning. After I was there as a student, they the main teachers of the conference asked me to join them as a teacher. So that's when I started teaching in about 2000. And but what prolotherapy is hypertonic dextrose. It's sugar water mixed with some novocaine and salt water. And originally, it was thought to tighten ligaments, strengthen ligaments, and strengthen the tendon attachments to our bones. And it does do that, but it also turned out to be good for arthritis, just injecting it into the joint. It's actually good for different kinds of soft tissue injuries, that things that are torn, like a muscle strain or a torn muscle. We can inject it into a torn muscle under ultrasound guidance, and lo and behold, it helps it heal. It's a simple solution. I've been involved in training doctors from around the world and treating the poor. We've had mission trips to different Central American countries like the Honduras and Mexico. There's other training trips that some of my colleagues go to all around the world. We were in Italy a year ago, and that we weren't treating the poor. We're treating the Italian nationals that were being invited to come in, and actually we treated a lot of the doctors too. But we are focusing on prolotherapy, and so it's being taught and used around the world. And it's unfortunately not covered by our insurance, but in some countries it is covered, and it's an inexpensive way to treat orthopedic injuries as opposed to surgery, or as opposed to a lot of these newer, fancier regenerative medicine treatment options. They can get much more costly. But prolotherapy I still use it in my practice every day. I probably do about 20 to 30% of my patients still get prolotherapy on a monthly basis.
Wow, that's interesting. So it sounds like you combine it with the other regenerative tissue.
Yes, we do.
Injection. So, and it's basically, that hypertonic dextrose, as you mentioned. So it's when you inject it in a specific sprained ligament tendon. So it creates sort of like a micro inflammation, attracts additional cells from our bloodstream. So,
That's
and
right.
kind of, it heals and also can thicken. So, ligament that is overstretched or partially torn. So, and that's the pathway to healing, correct?
That's correct. That's correct.
Yeah.
As long as we're ready to heal. And that's a whole nother topic of getting our patients ready to heal.
Right.
And some patients are not ready to heal, and we do these treatments and it doesn't work. And we're scratching our head. Why didn't it work? Well, maybe it's because they're drinking too much, or they're taking too many anti-inflammatories, or things like that. So there's lots of reasons why patients don't heal the way we expect them to, and we have to figure that out as their doctor.
Yeah, because I see the same thing. So, I do very similar procedure, the same tissue for the regenerative procedure, but two patients can heal completely differently. So for exactly the same pathology. So that's exactly right. So, and also you mentioned PRP, or platelet-rich plasma. So, and a lot of people don't even know that it's not like, brand new type of treatment. So it actually started in 1950s, 60s, so, and even in 1980s and 90s has been used for the orthopedic procedures, for bone grafts, malunion fractures, connective tissue repairs, for the periodontal surgeries, maxillofacial surgeries, cosmetics, skin grafting. So and then it of course started progressing more and more to all branches of medical field. So, and now of course we use it for musculoskeletal problems. So, and then you did mention, so there are of course several different types of tissue that we all use for the regenerative purposes. So we use dextrose, as you said. We use PRP, which comes from patients' own blood through the serial centrifugation process. So, and I remember you mentioned that there are already, so the fourth generation of the PRP that you have mentioned that you use, so what exactly that means?
So the first generation PRP was it was bloody. We knew it was red. It looked like we were injecting blood back into our patients, and blood is inflammatory, so it hurt. And there was a myth in the very early days that you could not add any Novocaine to the PRP or to the injection site. So you had to inject this very inflammatory, bloody solution into your patients to try to help them heal. And it was one of the most painful things you could put a patient through. And so we, scratched our heads and said, how do we concentrate the platelets, but keep the red blood cells out of it? And that became generation 2, was pure PRP or bloodless PRP, and it looked yellow. So it was just cloudy with platelets. And that was much less inflammatory, but still inflammatory. And then the third generation was making it very anti-inflammatory by we would add a drug or a chemical to the PRP and let it sit for a few minutes, and it would release all the growth factors from the platelets into the plasma. We would spin it again, and it would take all the broken platelet cell bodies. It would turn into like a little snot clot down at the bottom of the test tube, and we wouldn't use that. We would extract the plasma now loaded with the growth factors. All the white blood cells are gone, all the platelets are gone, and now you've gotten rid of most of the inflammatory proteins in the platelet-rich plasma, and we've saved all the good growth factors that were released from the platelets. We inject that into the patient, and it's not very inflammatory at all or not at all. Patients can go right back to work or right back to walking. If we injected an inflammatory PRP into their knee, they may have to be on crutches for a day or two until the joint calms down. But with the platelet releasate or lysates, those are the third generation anti-inflammatory growth factor injections. And then generation 4 is we're subdividing the plasma section. We know where the platelets are, we know where the white blood cells are, we know where certain proteins are, and we're now able to isolate out different sections of the plasma, concentrate that, and one of them is called PRGF or plasma-rich and growth factors. Another one that's not very inflammatory and still has good healing potential. It's a milder, lower platelet count, so it works to help our patients heal. But you may have to do 2 of them to equal 1 PRP. So, what you have to give the patient the option. Would you like to come back and get 2 treatments and not suffer as much and have to pay for 2 procedures, or go through some inflammation and recovery with 1 treatment to get to the same spot as the PRGF patients? So there's lots to discuss with patients to diagnose them, to give them a treatment plan that makes sense to them, that they want to go through with, and that fits their lifestyle and whatnot. So we can really tailor make their regenerative medicine treatment to fit their situation. And even some of the treatment options we have, the more we process the blood and whatnot, it gets a little more expensive because I have to use more equipment, more staff time in order to make these different generation PRPs. So we add a little more cost onto it. Some patients, that's a burden to them. So that's where Dextrose becomes really important in my practice. If a patient can't afford these more expensive regenerative medicine treatments, we'll offer them to Dextrose. Say, look, let's try this and see if this is strong enough. And if it's not, you can save your pennies and come back and do a more expensive treatment. But oftentimes that's all they need is some prolotherapy. So that's a lot of times that's what we end up offering them.
Right. But you still use, obviously the full array of the regenerative stem cell type of tissues, so
Sure.
that obviously, one category is patient's own, right? So as you mentioned, PRP, fat or micro or nano fat. So that comes obviously from the harvesting fat and a very easy injection-based procedure. So, and then you use bone marrow concentrate. I understand,
Correct.
right? So, and then of course the second separate category that comes from the other person, right? So like a perinatal tissue, so that you obviously use those 2 in Mexico, I understand, right?
Yes.
So
Yes, that's
yeah,
correct.
so we'll touch on that unique place where you do so many pretty advanced procedures. So, but yeah, it's definitely a very interesting landscape, and sometimes it's not easy for patients to navigate. So for what type of injury, what kind of procedure, is good or not. So, and I know that you wrote and published a book, Regenerative Healing for Life, kind of like a comprehensive guide for patients to understand how to treat their injury and how to, get pain relief without any surgery. So I think it's like really unique book that I would recommend to any patient who wants to make a sense of all of this. That of course hard to cover in one interview with you. So
Sure. Yeah,
because
it is.
it's been
It's
decades now.
I wrote the book for my patients to understand the difference of the two different treatment paradigms. One, I call it the traditional orthopedic paradigm of physical therapy, anti-inflammatories, and injections leading to surgery if you don't get better, versus regenerative medicine that we're talking about. And the book has lots of case examples. There's lots of medical references in it if the patients want to dive in to that, and so it's still available. And a lot of my patients have enjoyed it and have used it to. They see themselves in some of the chapters where they can come back to me and say, "Hey, I think I'm that patient in chapter 4 that injured his knee, and I think I need your help." So yeah, it's been fun.
That's great. Yeah, that's such a helpful tool, obviously. So, and then I want to talk to you about spine. So, back pain is, as we know, a leading cause of disability worldwide, and it's one of the top reasons for missed work and healthcare utilization in the United States, as we know. So, and I know you're very passionate about treating the intradiscal treating the degenerative disc or ruptured disc. So, and obviously, your passion comes, from the putting people back, into their activity without any surgery. So, and that is super unique that we did not have literally, 15, 20 years ago. So, as an option. So, yeah, tell me more. What's your approach to back pain? And
Okay. So as a prolotherapist, we treated a lot of spine patients, a lot of back pain patients, but there were certain patients, if it wasn't a torn muscle or a sprained ligament, maybe their SI joint was out of whack, they would go to a chiropractor and get temporary relief. We would do prolotherapy on those patients. A lot of them got better, but some of them didn't. And they had a very unique story where it was difficult for them to sit, and standing or walking was better. They couldn't lay in bed and sleep. If they were sleeping in on a weekend where they didn't have to do anything, their back would get them out of bed at about 6 hours, most of them would say. And that's a very telltale sign for me. Leaning over at the sink to brush your teeth or wash the dishes, their back would tighten up on them and cause them to seize up. Very unique story that is usually coming from the disc. The pain can radiate into one leg one day, can radiate to the next leg the other day. And that's that shifting or transitory pain pattern is the disc has been torn and it's leaking its contents one time out on the left and the next time out onto the right, hitting the nerves. These patients can get very painful spasms. They'll have to take it easy they'll maybe not lay in bed, but they may not be able to do a physical job. They'll have to stay home for a week or two, and then it goes away. They get better and they go back to work. But they always say, I have to be careful. I know I can feel my back is going to go out. My back goes out. That's a telltale sign of a disc.
Right.
And then the disc pain can radiate in very strange ways that can trick doctors into making a wrong diagnosis. So as I started seeing these patients' history patterns, and the other big part of their story is when they come in for me to examine them, I can't reproduce any of their pain. We have classic exam techniques that we can reproduce a herniated disc pain. We can press on different joints in the lower back that reproduces their pain, or ligaments or muscles. We can reproduce those patients' pain. But if it's just the disc is torn and painful for 10 years, they have a negative exam and they're being told it's all in their head, and it's not. They have the perfect story for a bad disc, and we put up an MRI of their neck or their back, and it shows horrible degeneration in their spine that the pain could be coming from. So that's the story that I want the audience to understand, is your story tells the diagnosis, and not that it may only be coming from the disc. There are lots of other things in the spine that can cause pain that we would treat with prolotherapy, or PRP injections, etc. But the disc is responsible for about 40% of our patients' chronic pain. So it's very common, it's very underdiagnosed. And when it finally is diagnosed, that we don't have very good treatment options unless you're running into someone like me that is experienced at treating the disc and trying to get it to heal. And so that's the story on disc. And as I was one of these patients in that car accident that I suffered back in like 2007. I tore discs in my neck and my lower back, and I didn't get them treated until probably about 2015. I went to a doctor in Vegas who did PRP in the two lower discs in my back, and it changed my view on putting something in the disc with a needle. And that's when I dove in. It was about,
Well, 9
actually
years
before
later.
15. No, it was actually 15 years ago that I got treated.
Oh, 15.
And
Wow.
that's what I started offering it to my patients 15 years ago. I've been doing this for 15 years. So that was
And
a
what?
big game changer.
So, what did they inject in your
I had
intervertebral disc?
I just had PRP back then, and it did help me. Wasn't perfect, and it did help me. And then in 2019, I got trained to do the disc procedure, and I was the last patient of the training day, and had 3 of my discs treated with the disc procedure, and that was 6 years ago. And my back is getting a little cranky. I'd like to get another one. You know, a lot of my patients say, is this going to cure my disc or my back? And it depends where we start. If you're a 20-year-old construction worker and you slip and fall carrying something heavy and you blow out your disc, that one disc, and it's still healthy, if we can treat that when you're young and healthy, it can cure it. And that disc will become just like any other disc in your back. But after you've
Wow.
gone through a windshield at 18 years old, and then 50 some years later, you're getting your spine treated. If you guys can see the image on the screen here, your spine ends up looking very badly degenerated, and those are hard to cure, but we can fix them and heal the actual tears that are painful, but they're at risk for further degeneration because they're already so bad as they get older, and as they, if they get in another car accident or a slip and fall or something, that could be traumatic enough to cause a new tear.
Right,
And that
right,
we may have to treat again.
right. And that brings me to another question. So, if you don't mind sharing, tell us about your 73-year-old patient who told you about his bucket list dream to climb Mount Kilimanjaro
Yes.
unassisted.
So I treated him with his own stem cells from his bone marrow years before that in his knees. He was an avid singles tennis player in his late 60s. And we fixed his knees. He was able to, his surgeons told him he needed knee replacements, and he played singles tennis for another 6 or 7 years before he came to me and said, I have this bucket list. I'm 72 years old and I want to climb Mount Kilimanjaro with my daughter. And I looked at him and I said, damn it, Jim, I'm a doctor, not a magician, as the old quote from Star Trek, if any of you guys are old enough to remember that one. And we got a good chuckle out of it. And they said, all right, well, here's what we need to do. I need to study all your MRIs and make a game plan, see what makes sense. And once we figure out your list of areas I'm going to treat, I need to calculate how much stem cell material we're going to need to treat all this. So it was obviously in a 72-year-old, if I use his own, I'm going to get enough stem cells to treat one knee, maybe 2 weaker treatments to treat 2 knees, but not 9 discs in his neck and back and 22 facet joints, both shoulders, both knees. That's way
Wow.
too much. That would have taken me years to do all that with his own tissue. So I've been going since 2019, we've been going to Mexico to use live stem cells in Mexico, where the labs down there can culture expand the cells, and we can order how many millions of cells and how many cc's of solution. They literally send vials over in ice chests, and we pull up the cells and treat all these different targets on the patient in one setting. So this patient ended up being treated by me for 6 hours. He had to recover. It took about 3 months for him to get through his healing. And then he went to PT, and then he started training for this climb. And I got a phone call on a satellite phone in the middle of office hours, and he told me who he was. He said, guess where I am? I said, over in Europe somewhere? He said, no, I'm on Mount Kilimanjaro. We just reached the summit. I was like, how could you call me? It was crazy. But he thanked me for treating him. He said he couldn't have done it without our work. And that's him
Wow.
on the left there at the peak of Mount Kilimanjaro. And
That's amazing. That
he
is,
just came in. He just came in a couple of weeks ago. This was probably 2 years ago now. He came in a couple of weeks ago. He wants to climb Mount Everest. Evidently, you don't have to go all the way to the top Mount Everest. You can go to the base camp, and they do little climbs from the base camp at higher than Mount Kilimanjaro. And he's still doing well, and he's got a couple targets for me to hit to keep him tuned up. But this slide here is his neck, and if you look down, the gray structure going through the canal there is the spinal cord, and the black little spaces are his cervical discs, his neck discs. And there's one with a little white spot, and then the one below that looks kind of foggy and blurry. That one was actually pinching his spinal cord, and he was getting symptoms in his arms and legs all the way down to his fingers and toes, where he felt like everything was asleep. And so that was a big target for me to get some of the stem cells in there. And we combine the stem cells with the disc seal procedure, or the fibrin glue that disc seal is known for, but we do both. So I think we're getting a better mousetrap to try to fix these bad discs when we combine those two. So here on the left, the third or the second disc down looks like it's almost gone, and the bones have shifted, and the black is pinching into a spinal cord. And then when you go to the right, 1 year later, it's no longer pinching the spinal cord. It's improved some. There's a little bit more
wow.
space if I blew this up. So that's
Yep.
a pretty remarkable change with a simple injection into the spine, into the disc. And there were
Yeah.
other changes too.
And I can see that here, if you go back to the neck, yeah. So I can see that the height of the disc, or how plump the disc is definitely improved
Yes, especially the
after.
really, really bad one increased some, but the ones down lower, 1, 2, 3 down lower, if you compare those two,
Yeah.
dramatic difference in thickness.
Yeah, that's really
So
amazing. So, and there
yeah,
is almost,
and
seems like there is a little reduction in that offset, which we call
yes,
spondylolisthesis. So, looks like
yes.
the ligaments are tighten up or something. So,
Yep. Yeah. And
wow,
I
that's
did, whenever I do this work down there, we combine this with ligament work and facet work. So we treat the whole functional spinal unit, not just the disc. We treat the whole person, so to speak. So that's an important part of what we do. And
wow,
the next slide is more subtle changes, but there's some improvements here. On the left was the original. On the right is the 1 year later. And Irina, you would recognize this. The bottom two discs have some modic changes.
yes.
And when we go over to the other side, the bulges are smaller and the modic changes are gone.
Yeah, which
And
is type of an inflammation inside of the vertebra or bone itself. Yeah, this
what
is
I,
what
I
we
like
got
to
to know.
explain to patients, when we see that change in the vertebral body or the bone between the discs, that's the disc is failing to do its job as a shock absorber. And now that gravitational force is beating up our vertebra, the bone, and it's causing it to swell, and that can cause pain too. So when we
Okay.
do these treatments and heal these tears, we often see the modic changes or bone swelling in the vertebra disappears. And it's really an amazing sight to see when we get the privilege to repeat their MRIs a year or so later.
Right, because you're not only improving the disc itself, which is where you inject, of course, the stem cells, but through the
Correct.
diffusion, so the end plates or of the vertebrae are also getting certain nourishment, if you will, right? So,
Yep,
and
it
those
is.
substances, of course, are anti-inflammatory, antimicrobial, right? So, and regenerative. So, you're
Exactly.
yeah, you're hitting all the pathways for the improvement. So, yeah. It's really impressive. So, and do we have another slide here? So this is the last one for the back.
Mm, Last
Last one.
one. Okay, good.
Yeah.
Yep,
Okay.
yep. Yeah, so that
That
was
was.
just a quick
Thank you for
case to,
sharing. Yeah.
yeah, to show an amazing case, amazing guy, and show his before and after on the power of this treatment. And not, we can get very good results with our patient's own tissue here in the States. But if I have a patient, a very unique patient like him, where he had so many things I needed to treat in a short period of time, and it's very expensive to treat that many areas. And this patient is a well-to-do gentleman, and we elected to jump on that option. And it's a nice option to have to offer patients that we can do something stronger, bigger, and maybe accomplish a lot of improvement in a lot of areas all at once.
I mean, that is absolutely remarkable. I mean, you injected, you treated his 4 discs in the neck, 5 discs in the lumbar spine, 24
Yep.
facet joints, ligaments, tendons, all the soft tissue. So that is definitely a lot of work to do in
Yeah.
one procedure. So, and yeah,
And
and that.
my staff is my two daughters are in the OR with me. My one daughter is a physician's assistant, and she's scrubbed in as my OR nurse, and my other daughter is the prep nurse that prepares all the different tissues and syringes and whatnot. So it's a family affair.
That is amazing. Oh, I love that. So, again, the difference between what you do in Mexico versus the United States in your clinic, so is that according to our FDA regulations, we cannot do the tissue expansion,
Correct.
or of the cells, obviously, or incubate them for a month or so to increase the number of those stem cells. That obviously gives you enough of volume to treat multiple um, uh, sites. So, but uh, are those cells, in your Mexico center, are those cells coming from the patient, or are those cells coming
No,
from
they're
the
coming
parent?
from a placenta. So moms deliver by C-section. They donate their placentas to the hospital. The hospitals sell them or donate them. In the United States, they donate to tissue companies. The tissue companies take them into their lab and they prepare the tissue. They send some of the tissue to quarantine to get tested, and it has to clear standard testing for infection and disease to make sure it's safe to go back into another human. And the wonderful thing that a lot of patients don't understand about placental tissue products is their immune privileged tissue, which means when our moms were carrying us, the placenta was this miraculous tissue that separated the baby system and their blood and tissues from the mother's tissue. And without that placenta, if those two people tissues mixed together, there would be a rejection, and the mother wouldn't be able to carry the baby, and it could actually kill the mom and the baby. So that anti-rejection tissue is the placenta. That's the miracle of the placenta that allows us to use different products from the placenta, from the umbilical cord blood, the covering of the placenta, the amniotic fluid. We can inject that into another human being without the risk of rejection and causing all kinds of immune responses or allergic responses. Can you get an inflammatory flare from those tissues? You can. And some people would say that might be because of the different tissues mixing together. But if in all my years of using these placental tissue products, they're no worse than a PRP injection. And they're usually much quicker to get through. It's usually just a day or two before you're through it, and patients are already noticing improved symptoms. So it can have a remarkably quick turnaround from injection to symptom improvement compared to our own tissue. So a lot of doctors like it because of that. We can just pull it out of a vial, inject it in our patients. The patients are happy. They heal up quickly. But when you compare each product side by side to what we can inject in our own patients, there's subtle differences and advantages of both. So one treatment might be, the placental tissue product may be the right tissue to use in one patient, but it's not in another. And they are also not covered by insurance, and they all have costs, and there's slight differences in cost depending on what we're going to do. And there's exosomes. You probably have heard a lot about exosomes on the scene, which are a byproduct of growing stem cells in the lab. And they're little tiny vesicles that have a lot of anti-inflammation properties to them. And they're nice to add into a stem cell treatment or use them by themselves as an anti-inflammatory treatment. Are they as good as a PRP or a stem cell treatment? All that kind of questions and answers still needs to be borne out with good, solid research. So there's a lot of doctors using exosomes. It's kind of the new hot shot on the scene. And
anti-aging, yes,
yes, yes. So
intravenous injections,
yes,
right?
so there's a lot of claims being made on it with not a lot of evidence on exactly how good it is or what it is. It as good as a bone marrow stem cell or as an umbilical cord stem cell? I'm not sure if it is. I've used them quite a bit, and they do have a role, and I am seeing some good results, but I don't think they're as good as a stem cell in my experience so far.
Exactly my experience as well, I have to say. Yeah. And
Good.
then who is the ideal candidate, do you think, for stem cell therapy? And are there any situations where you'd recommend against it?
If a patient, so to answer the last question, Irina, if a patient comes to me and wants a stem cell treatment, they have something pretty advanced going on degeneration wise. They're looking at a joint replacement in their knee, and I want stem cells. I've heard it's the best thing since sliced bread, and they had breast cancer 2 years ago. We're trying to do things safely, and there is a rule in our regenerative medicine world that if a patient had cancer less than 5 years from a cure, so they had the cancer surgery 2 years ago, they still have 3 years before they're considered a cure if it doesn't come back, that we should not do certain types of stem cell treatments to those patients because of the very tiny risk that we could be taking their tissue and putting it back into their body and causing a spread of the cancer. Even PRP, I just recently saw an article about cancer cells being spread by PRP. So we have to be careful using the patient's own tissue. Now, can we take placental tissue and put it in that patient without the fear of cancer? The answer is it's safer than using their own. But you could probably still find naysayers to say, there could be a tiny, tiny risk of even doing something with someone else's stem cells. So it would be a lot of counseling going on. What's the risk versus benefit with the patient? I want that patient involved in that discussion if we decide to do this as a family, as a patient, as their treating doctor, I want everyone to be on the same page, and we're going to accept the risk that we know. And if the risk is too high, they have to live with it, or they go to surgery or something else. There's other options to do than go down that path that we feel is not a match for them because of risk.
Right.
So that's.
Yeah, that makes sense. And but the prolotherapy, they would be still candidates for prolotherapy,
Yes,
obviously,
absolutely.
right? So it's not that they have no
So that's
other
that's
options.
nice to have the toolbox that we have. We have lots of different tools that we can reach for to help our patients depending on their situation. Yes, yeah. So.
And what are the like people need to know about potential risks, side effects, limitations that the patient should be aware of in addition?
So the biggest risk, well, the doctor needs to arrive at the proper diagnosis. I cannot say that enough to the audience, that when your doctor is saying, "Oh, I'll just do a little," you have, I literally hear this in my community where the patient goes in and says, "I have knee pain." The doctor does not touch them and says, "Hey, I could draw some blood and we can shoot some PRP in your knee right now." And there's no diagnosis. You don't even know if the pain's coming from the knee until the doctor makes the diagnosis. And they're paying, hundreds of dollars to have this treatment done. And they come to my office and say, "I already had PRP and it didn't work." And I said, "Well, here's your diagnosis. What did your doctor diagnose?" "He didn't touch me. He didn't do any x-rays. He just shot the PRP in." I was like, "That's crazy." So the number one important thing is a doctor needs to take a history, do a physical exam. There's usually a need to review imaging, x-rays, MRIs, ultrasound, and then we arrive at a proper diagnosis, an accurate diagnosis, and then a treatment plan could be hatched from that diagnosis. It could be designed specifically for that patient's problem. And then we have options based on these situations we just talked about. But PRP is a good starting point. Prolotherapy is a good starting point. If they're really bad, if it's a grade 4 advanced bone-on-bone arthritic joint, that's where I start getting into the more advanced therapies like bone marrow stem cells. If it's many different
depending
areas,
on the stage of that arthritis.
yes. So mild arthritis, prolotherapy and PRP works great. But more advanced, those treatments fall down, and the stronger treatments become more viable.
Right. Yeah, and as you mentioned, unfortunately there are a lot of cowboys, I call them, so like,
Yes.
some primary care doctors go for 1 weekend course on regenerative medicine and start injecting in the soft tissue and then tell my patients, like, "Oh, you just had the facet joint injection." So, and when I end up in my clinic, so they're like, "No, I don't want that because I already had it done and it doesn't work." I'm like, "Well, tell me more, was it a guided procedure, right? So was it diagnosed with the MRI or other imaging, So yeah, it definitely is important how patients choose their regenerative medicine provider. So if it's done in a guided manner, just as a procedure itself rather than blind injection, we know how many huge percentage of the even simple knee injections are missed by orthopedic surgeons if they don't use ultrasound or some other guided imagery. So yeah.
I agree. Totally agree.
Yeah.
And then the other thing with in individual patients is what are we doing with the product? So we have all different kinds of PRP out there. There's what some of us call fake PRP, where it's only got a platelet count of whatever the body's platelet count is. That's what's in the PRP. It's not platelet-rich plasma. It's just plasma, and plasma is not the best regenerative. I'd rather have that patient get prolotherapy than just plasma out of their blood. That's not going to be an effective treatment. And that happens a lot also, where patients are getting, or their doctor is combining something I've heard of doctors combining bone marrow stem cells with ozone gas. Ozone gas is an orthopedic treatment that's practiced a lot in Europe, not that much here. I actually use it in discs in patients with bad herniations, and it helps shrink the herniation. It helps shrink the disc, and it works very, very well. But if you combine ozone gas with stem cells, it kills the stem cells dead. And doctors are doing a $5,000 treatment of stem cells into a knee, and they're adding ozone, think they're combining two good things, and they're not. They don't understand. So there's all these stories we hear, and the doctors need to be knowledgeable and have the experience and do things the correct way to help their patients and not waste everybody's time and money.
Yeah, exactly. And then would you share with us like what is the recovery look like? And of course, there is probably different recovery from the injecting inside of the disc versus injecting into the joint. So, but
Yeah, so for like a PRP into a joint, we ask the patients to give it 8 weeks to calm down and heal some. Now, if it's a soft tissue structure like a tendon or a ligament, that's going to take about 100 days to heal. So we often will interrupt that healing process, see them back in, look at the tissue, and offer them a booster, because the last little bit of healing that takes 4 to 6 weeks is the slowest, smallest amount. So oftentimes we know they're going to need more than one treatment. So we'll do it early and stack the treatments on top of each other. So by the time we see them back 8 weeks later, they're doing really well. A stem cell treatment is usually a one and done. It's usually about a 3-month recovery to the point where they're getting about 80 to 90% of their healing. And they'll continue to heal even after that. But that's when we would ask them to refrain from going back to hard sports and things like that. They're able to start doing some soft therapy and starting to get ready to go back at about 8 to 10 weeks. But the tissues need about 100 days to fully heal. Or otherwise, they could slip backwards and come back in and say, "Hey, my pain's back," and then you look and the tissue hasn't healed.
right.
In the disc, it takes about an extra month to heal. The disc is a avascular structure. There's no blood vessels in it, and it takes longer for them to heal. And if you do certain things too soon, we're putting a clot of biologic tissue inside the torn up disc, and we're asking those tears to heal. That clot has to turn from a clot, an orthobiologic clot, to healed tissue. And it takes, if we're using cells in there, it takes about 3 to 4 months. And if we're not using cells and just using disc seal, it usually takes 4+ months. So it takes a little longer if we're not using something in there. They both work. I think using cells with the fibrin glue is a stronger construct that I think helps more difficult conditions to get better. Even in joints and tendons and ligaments and whatnot, we're seeing really good results.
Right. And as I tell my patients that it is a biological treatment. So, and biology in general is very slow, but it is robust, right? So,
Yes.
and we can.
Patients will say, "Hey, I'm here to get PRP because I'm going to heal faster." And I said, don't look at it that way. I'm going to heal something that's very, very hard for you to heal on your own. And we're going to try to avoid surgery, but it's going to still take Mother Nature time to get to that endpoint of healing. So I try to dispel that myth out there that it's a faster healing process. We can't change Mother Nature. Mother Nature still has to do what it has to do.
Right. Yeah. Well, where do you think that this field is heading in the next 5-10 years? So there are some most exciting developments in.
There's I am in the process of transitioning my practice I've been working at for more than 15 years here, and I'm going to be moving to Florida in the fall. And Florida just announced it's going to legalize stem cells. So
wow, that's impressive.
now from my reading of the law goes into effect in July. From my reading of the law, we're still not going to be able to culture expand or incubate the cells and grow them and then use them in our patients, but we can use placental tissue products, and we can use the patient's own bone marrow, fat, blood to treat their orthopedic injuries. And some of the other things that we're doing in Mexico, we're doing IV treatments for an immune system boost to help their orthopedic condition heal better. I think from what I'm reading that we're going to be able to do some of that in Florida. So it'll be interesting to see all the details of that law when it comes out. But it sounds like it's going to open up the state of Florida to be able to do a lot of the things we're doing in Mexico, except culture expand. So I'm still going to have to limit the number of areas I treat in Florida, but I can do a better job legally in Florida than we have been doing around the rest of the United States, where doctors are still using these placental tissue products in the shadows because it's not kosher with the FDA. In Florida, it's going to be.
Wow,
So
that's
exciting. Yeah.
Yeah.
And hopefully with hopefully with the HHS director, I understand he's been a victim of some orthopedic things like ciprotoxicity. If some of you out in the audience may have
R-
heard of that.
right,
Uh,
RFK Jr., who had
yes, he
cells
was
treatments.
very disabled with ciprotoxicity, and he was saved with IV stem cells. And so he's a believer and wants to see a lot of these therapies approved in the United States, and the FDA has been slow to approve, and hopefully things will change where we can still do safety and do it right and get things approved the right way, but not have the long, expensive barriers that the FDA traditionally puts up for new treatments.
Right, right. And then just in general, how risky are these procedures, like compared to surgeries, cortisone
Yes, so
injection?
there still is risk. There still is an infection rate when we do an injection. The medical literature, the orthopedic literature says if I inject your knee, we have a 1 in 50,000 times risk of causing an infection, even if I do things perfectly correctly. And so there is still risk. And there's a lot of doctors that don't do their procedures correctly. They don't clean the skin the standard way. They maybe have the needle right here in front of their mouth while they're talking to their patient about their grandkids, and then they stick it into the patient's knee and they've spit all over the front of the needle. And that is a high risk situation. You cannot do that. Doctors have to be very aware and very careful on their procedural techniques and do it the standard way that we're supposed to do it in our community. And with that, I've done between 700,000 and 1 million injections in my practice in 33 years, and I've had 2 infections. And both infections were in high risk patients. One of them didn't tell me she was high risk until I found out later.
What
And
does it
but
mean? Oh, Brian, high risk.
one of them had chronic Lyme disease and had several other co-infectors that was being treated, and she didn't divulge that to me. So she probably had bacteria in her knee already, and I did a PRP injection into her knee, and it got infected. And it was during COVID, and we had a terrible time getting her diagnosed because of hospitals and labs and samples being missed and lost. And it took us about 3 or 4 weeks to finally make the diagnosis. And then I got a surgeon 3 states away to do the surgery to clean her out. And I fully expected her to have her joint replaced. But she was a alternative medicine doctor, and she went to her doctors out on the West Coast of the United States and had ozone treatments and all kinds of different peptides and whatnot. And her knee ended up healing perfectly. So it's a very unusual case that got badly infected, had a delay in treatment, but ended up having a good outcome. Usually those cases end up with joint replacements. And we can cause infections in the disc, and there's lots of theories on that, but I've been doing it for 15 years. We've never had a problem in our patients. I've treated hundreds of patients in my time in these 15 years. So I think there's a difference in technique and risk between doctors and clinics and hospitals, and the risk of causing an infection in the disc is real. It's very small, and in some clinics it's higher than others. But you have to do your research and find out from the treating doctor what is that history in the doctor's office. Have they had any infections and whatnot? And if they admit to it, you keep shopping and find someone who hasn't and is using good technique.
Right, right. Well, you have definitely an amazing track record. 2 people out of 1 million, so that is definitely impressive. So, yeah. Where can listeners learn about your work or get in touch if they're interested in exploring treatment options?
So my website, I'm sorry I don't have a business card to show up on the screen here, but it's a very simple website, drshiple.com. So dr, my last name, shiple.com. And that website is well designed, has all the information you need to contact us. And we actually have the ability for patients to upload their MRIs to a website sharing service called mymedicalimages.com. And I have an account there, and patients can upload their MRI images for free, and I can get on the phone with them and talk to them about their case and see if they're a good candidate for one of our treatments.
Oh, that's amazing. Yeah. This has been a fascinating conversation, Dr. Shiple. Thank you so much.
Thank you, Readiness. So good to see you again, and look forward to seeing you soon.
Yes, so we should maybe reconvene and do another interview in a few years, because I'm sure this field, is growing exponentially.
Changing. Yes, it is. There's so many exciting things happening.
Yeah.
All right.
Yeah.
Thank you very much.
Yeah.
Okay. Take care.
And thank you for joining us at Cures, Remedies, and Beyond, exploring science and the wisdom of health and healing. We hope to see you next time.
This podcast represents the personal views and opinions of the host and the guests and does not constitute medical advice. The statements contained in this podcast have not been evaluated by the FDA. Any products or treatments mentioned are not intended to diagnose, treat, or prevent any disease. Cures, Remedies, and Beyond podcast with Dr. Irina is bringing together the science of medicine and the art of healing for ultimate vitality and health.